A child with hematuria and edema following pharyngitis. How to confirm post-streptococcal glomerulonephritis and choose a treatment. Diagnostic standard. Clinical presentation takes precedence over morphology. The diagnosis of acute post-streptococcal glomerulonephritis, APSGN, is established clinically. The basis is a combination of acute nephritic syndrome with anamnestic or serological evidence of a recent streptococcal infection, throat/skin. Laboratory marker C3 component. It is important to remember that hypocomplementemia decreased C3 levels in APSGN is usually transient. C3 levels should normalize within 6 to 8 weeks. If the complement deficiency persists longer, the diagnosis of HPSN should be reconsidered in favor of other pathologies, such as C3 glomerulopathy or lupus nephritis. Renal biopsy is not recommended in routine cases. It is indicated exclusively in cases of atypical course or signs of severe, rapidly progressive kidney damage. Advanced diagnostics, determination of the plasmin receptor. NAPLR may help in complex cases to confirm bacterial etiology. Therapeutic approach, symptomatic management. There is no pathogenetic treatment for uncomplicated acute pyelonephritis. Main strategy, supportive therapy, diuretics to control edema and antihypertensive drugs to correct blood pressure. Role of antibiotics, prescribing antibiotic therapy. Once acute post-streptococcal glomerulonephritis has already developed, does not affect the course of the nephritis itself. However, it is necessary to eradicate the source of infection, if it is still present, and to prevent the spread of nephritogenic streptococcal strains in the community and among family members. Reserve, immunosuppressants, or renal replacement therapy are used only in cases of severe complications. Prognosis and hidden threats. Although most children make a full recovery, there is a risk of developing persistent proteinuria, hypertension, and CKD. Long-term follow-up is mandatory. Markers of poor prognosis. Severe initial kidney involvement, persistent infection, presence of genetic complement defects. Epidemiological concerns. The proportion of glomerulonephritis cases associated with staphylococcal infection is increasing, and their clinical course differs from that of classic post-streptococcal glomerulonephritis. What changes should be made in practice starting tomorrow? Avoid routine biopsy in typical patients. Monitor C3 levels over time. Normalization after 2 months confirms the diagnosis. Use antibiotics for epidemiological control, not for treating kidney damage. Focus efforts on managing hypervolemia and blood pressure. The epidemiological situation is changing. In developed countries, the incidence of GBSN is declining, while in low-income countries, it remains high. At the same time, the frequency of glomerulonephritis associated with staphylococcal infection is increasing, which differs in clinical course and management strategy.